بسم الله الرحمن الرحيم. أنا الدكتورة أميرة مصطفى Consultant Medical Retinal and Retinal Imaging في Eye Care Eye Center. هتكلم معاكم بسرعة على Retinal Venous Occlusion Review. The Beaverdam Eye Study estimated the 15-year cumulative incidence of retinal vein occlusions at 2.3% in the population, with 78% of cases being branch retinal vein occlusions. Systemic vascular diseases such as hypertension and arteriosclerosis are risk factors for branch retinal vein occlusions, probably because they lead to thickening of retinal arteries. Other risk factors include hyperlipidemia, diabetes, smoking, elevated plasma homocysteine level, and low serum folate level. Local or ocular risk factors also include glaucoma and ocular inflammatory conditions. Branch retinal vein occlusions occur mainly due to turbulent blood flow, secondary to compression of vein lumen at crossing site with an artery, as they both share common adventitial sheath. Also, presence of vitreomacular adhesions at AV crossings can increase the risk of compression. Also, local thrombus formation in a vein can occur. On the other hand, the central retinal vein occlusion occurs in older patients, especially those with diabetes and hypertension. Most cases are unilateral, with 7% contralateral eye affection in 5 years. Central retinal vein occlusions occur due to thrombus formation within the lumen of the central retinal vein at or just proximal to the lamina cerebrosa, as the central retinal artery and the vein are aligned parallel to each other in a common tissue sheath in the retrolaminar portion of the optic nerve. Other mechanisms of central retinal vein occlusion include retrobulbar compression secondary to mechanical stretching of lamina cerebrosa, as in cases of elevated intraocular pressure, compression by adjacent atherosclerotic central retinal artery, or hemodynamic alterations with subsequent stagnant blood flow and thrombus formation known as Virchow triad. According to the CVOS study group, retinal venous occlusions can be classified into perfused, non-perfused, or intermediate based on fluorescein angiography characteristics. A well-perfused central retinal vein occlusion shows lesser retinal hemorrhages on presentation, area of retinal ischemia less than 10 disc diameters, and has better initial and final visual acuity. About 30% of well-perfused cases will turn into non-perfused after 3 years. A non-perfused central retinal vein occlusion shows denser retinal hemorrhages, cotton wool spots, and macular edema on presentation, areas of retinal ischemia more than 10 disc diameters on fluorescein angiography, and of course poor visual acuity at both presentation and at conclusion of treatment. At 3 years, those patients will have 45% risk of developing neovascular glaucoma. Clinically, some patients may be asymptomatic, the others may show painless diminution of vision, visual field defects, or vitreous floaters. 11 to 40% of patients may present with complications such as ischemia, neovascularization, and vitreous hemorrhage. In these slides, we can see the signs of venous occlusions, including dilated, tortuous, one or more venous arcades, blood and thunder appearance, macular edema, disc edema with peripapillary hemorrhages and cotton wool spots. Another picture of well-perfused central retinal vein occlusion showing dilated tortuous retinal venous arcades, disc edema, peripapillary splinter hemorrhages, deep and superficial retinal hemorrhages, and macular edema. This is a case of superionasal macular tributary occlusion with macular edema. A case of superior branch retinal vein occlusion with areas of ischemia in fluorescein angiography corresponding to cotton wool spots, retinal hemorrhages, and of course macular edema. Another case with more dense macular edema. Another case. This is the last patient after resolution of macular edema, and we can see the sclerosed tributaries that were previously occluded with regressing cotton wool spots and the complete resolution of macular edema on OCT. This will take us to the signs of chronicity in patients with previous venous occlusions, which include resolution of retinal hemorrhages, resolution of macular edema, which is more persistent than hemorrhages and the cotton wool spots, formation of optociliary shunts, retinal ischemia, formation of anastomotic vessels between ischemic and well-perfused retinal areas, neovascularization, again retinal ischemia, and vitreous hemorrhage. Management with my colleagues, Dr. Ahmed Souka and Dr. Mostafa Al-Marhali. Thank you.